Despite the excellent responses seen in SOLO-1 and outcomes, we still have patients who are recurring. We hope it's far fewer than in the past. And certainly even with bevacizumab and the advances there, we still have patients with recurrent disease. And so the considerations are very similar, but some differences to how we think about the next subsequent line of therapy. Certainly, we look at the appropriateness for retreatment with platinum as a key indicator. So this is based on how well the patient tolerated platinum the last time and the time period and how well they responded and the time period from that platinum-based therapy. And the dogma has been if that time interval is greater than 6 months, you would reuse platinum. What has changed, however, is this dogma that if it's less than 6 months, you would not reuse a platinum. And that has really been challenged among patients who responded beautifully to platinum in the last line of therapy and only recurred when you stopped it versus those patients who didn't respond at all. So one difference is that we're really looking at patients whose tumors, because patients don't fail, but tumors fail. So patients whose tumors failed to respond to platinum are really inappropriate for platinum again. Patients whose tumors respond to platinum, and the longer they respond, the better. But even if they recur in less 6 months, there's still a consideration for platinum. And so that definition is changing, which I think has helped patients get re-exposed to the best drug we have so far in ovarian cancer. And I think that's helped push out some of the progression-free survivals we've seen in the recurrent setting. So that's one change just in kind of definitions and how you categorize patients into these recurrences. Of course, you still consider residual toxicities, patient decision-making regarding schedules, and all of those sorts of nuances that are very important to select the next line of therapy. But here again, knowledge of the patient's genetic profile, does she have a BRCA mutation or another mutation that may impart a potential benefit for PARP inhibitors, such as RAD51C, potentially PALB2, potentially BRIP1. We're thinking about all of these and doing studies, but does she have a genetic profile that would make you want to use a PARP inhibitor if she has not seen a PARP inhibitor yet? And have you looked in her tumor? And does she have anything in the tumor, specifically a somatic BRCA mutation, but all of those other mutations can also be somatic, that again would make her likely to respond to a PARP inhibitor in the recurrent setting. And the other wild card is this homologous recombination deficiency assay, which doesn't test for those specific genes, but what it looks for is evidence in the tumor that the tumor struggles to fix its DNA. And so if the tumor struggles to fix its DNA, that is a predictive biomarker of response, better response to a PARP inhibitor than someone that does not have evidence of that in their tumor. And so we have seen several studies. NOVA evaluated niraparib as a maintenance following response to platinum in the recurrent setting. Ariel 3 studied rucaparib in the same population, and SOLO-2 and Study 19 studied olaparib in that population. And each of them had biomarker programs. They're all a little different, but in summary, you can say the patients who had a BRCA mutation, either germline or somatic, did the best if you used a PARP inhibitor following response to platinum-based chemotherapy. And again, this is all PARP inhibitor naive patients. Patients who had evidence of homologous recombination deficiency in their tumor did next best. And then those patients who had neither a mutation in BRCA or evidence of homologous recombination deficiency did the least best with PARP inhibitor, but they still benefited from the PARP inhibitor. So while homologous recombination deficiency assays are helpful, they don't delineate a population of patients who don't benefit from PARP. And so that's one of the struggles we have, because again, in the second line, platinum-sensitive recurrent setting, when you have a patient sitting in front of you, you have to make a decision about whether or not you're going to use bevacizumab with the chemotherapy, which again improves responses, and that's incredibly important when you have a symptomatic patient, and then bevacizumab maintenance, or you're going to just use chemotherapy and hope for a good response, which happens about 50% of the time, and then hope to put her on a PARP inhibitor. And again, this assumes a PARP naive population. So that's a very different scenario than the case we discussed previously. And there isn't a head-to-head study of bevacizumab as a maintenance in that population and PARP inhibitor as a maintenance. So outside of a patient with a BRCA mutation, you really can't say which one is better, because the studies that evaluated these two agents are entirely different populations. And so I think I've listened to a lot of experts kind of devise an algorithm that works for them. In my practice, I don't want any non-BRCA patient at this point to not have access to a PARP inhibitor. Because as I said, there's nothing that tells me yet who shouldn't get one. So this may be the only opportunity in this setting for a patient who does not have a BRCA mutation to access a PARP inhibitor at this point. And so I tend to use a PARP inhibitor here, use platinum-based chemotherapy, whatever doublet makes sense for my patient, try to get them into a good response, and then move to a PARP inhibitor, just trying to avoid the potential that should she be platinum resistant, I can't get her a PARP inhibitor later. Other experts really believe in the overall survival benefit demonstrated with bevacizumab. It's modest, but it's there. And so they're going to start with bevacizumab, and even probably more people start with bevacizumab and then decide later what they're going to do, for which there's no data, but a lot of people do that. And so I think this line of therapy has become very complex. And now we're using PARP in the front line, and so we're going to have fewer PARP-naive patients coming in. So I think this is an area where we're going to see shifting sands in terms of standards of care.